Okay, so let's take a look at some obstructive pulmonary disorders. Obstructive pulmonary disorders are manifested by an increased resistance to airflow. We're going to take some examples of those. And they're classified according to these, and we'll talk about that. So, obstruction from conditions in the wall of the lumen. What are examples of that? So, there's an obstruction is caused by some kind of issue in the wall of the lumen, and the lumen is that, think of it as the tunnel in the lungs, right? So an obstruction is caused because there's some kind of issue in the wall of the lumen. And some examples of those are acute bronchitis, asthma, and chronic bronchitis. Then there's also obstruction that can be caused by loss of lung tissue, like emphysema. Other obstructions can be caused because there's an obstruction of the airway lumen itself, an obstruction in the airway tunnels itself. And these are some examples that we're going to be looking at. So, what about asthma? I mean, that's really common, right? So, asthma is a lung disease that is reversible, but not completely in some patients. It is caused by some kind of airway inflammation, and also it can be caused by an increased airway reactivity to something, like in an allergy, for instance. So, what are the things that we see when people have asthma? I mean, you've seen what asthma looks like. Patients are having difficulty breathing, and usually they're having wheezing. So, paroxysms are that they're having they wheeze and then they kind of stop and then they wheeze again. They're just having a lot of difficulty getting air out. So they're short of breath, dyspnea, and then they'll have these coughing because the bronchi are constricted, so they're trying to clear their airways, and so they start coughing a little bit. So the pathophysiology of asthma can be intrinsic or non-allergic, sometimes referred to as adult onset. It can be extrinsic, and this is also called allergic, sometimes referred to as childhood asthma. And asthma is thought to involve inflammation of the airways, right? Most cases of asthma can be triggered by some kind of allergen, some kind of stimuli like exercise or exposure to cold air or peanuts. The terms intrinsic and extrinsic are still used, but we use non allergenic or allergic. There are 5 phenotypes of asthma, and these are early onset asthma. It could be a late onset eosinophilic asthma. It could be exercise induced. It could also be obesity related. And there's what they call the neutrophilic asthma because it's some kind of response to something. And so the immune system responds to something that the airways encounter, and so the neutrophils are released into the system. It's neutrophilic asthma. So these are your immunohistopathologic features of asthma, and there's what they call denudation of airway epithelium. So denudation, gosh, I can't talk today. So denudation is stripping. It's the stripping of airway epithelium. And when they're stripped, they're obviously, it's not a good thing because you need the airway epithelium, right? So there are collagen that are deposited into the basement membrane, then edema follows, then you have mast cell activation, and then you have these inflammatory cells that are infiltrated by neutrophils, eosinophils, and lymphocytes. And what happens there is you end up with inflammation that contributes to that bronchospasming, to the mucosal swelling, and you have these mucus plugs that form, and then your airway starts to remodel itself. And as you can see in the picture there, you have the lung without the asthma, and you got nice airways, you got the lumen is nice and wide, your muscles are relaxed and airways are open, and you have just amount of mucus to um, to moisten the airways. But in asthma, you have these muscles that are tightened, the airways are swollen, and so there's hardly any room for any air to get through. And some patients just have this a genetic disposition and predisposition, unfortunately, to asthma. So let's take a look at um, allergic asthma. It is mediated by IgE, and it's pretty common. So what you'll see with allergic asthma is that when they do blood work, the IgE will be elevated. It can be seen in allergic rhinitis, eczema. Also, patients have usually have some kind of positive family history of allergies, and the attacks can be seasonal. It can be environmental or occupational exposure. I had really bad asthma when I was a kid. Thankfully, I don't have it now, but I do react to cleaning products. So when I like clean the bathroom or something, I have to do it in stages because just a little bit of chemicals, I just can't breathe anymore. So, okay. So the mechanism of asthma is usually initiated by some kind of exposure to an antigen that the airways have been previously sensitized. And when that antigen reacts with the antibody on the surface of the mast cell, certain chemical mediators are released into the bloodstream. And there's a lot of things that are released, the chemical mediators, bradykinin, eosinophils, serotonins, all kinds of cytokines are released. And with the release of chemical mediators, the normal respiratory epithelium, we already said this, why I couldn't pronounce it at first. So the epithelium is denuded or stripped, and they're replaced by goblet cells. And goblet cells, those are the ones that produce mucus, but because now there's more goblet cells, it produces more mucus. It results in mucosal edema. And there's more production of inflammatory exudates, and then there's hyperresponsiveness of the airway. So what happens here is now you have bronchoconstriction, and that alteration in that epithelia integrity leads to microvascular permeability. So fluid starts leaking out, which is, we don't want that. We don't want fluids leaking out to the lungs. um, so a secondary mediator response occurs after 6 to 12 hours after that primary asthma attack. And when this happens, it is so hard to get them back. It's very hard to open up those lungs again. And usually these kids are so sick. So what do we see in asthma? Well, the usual, you see them, they're wheezing, they're holding onto their chest because they're having a hard time breathing. They have dyspnea, again, we said that, difficulty breathing, and that cough. They're trying to clear out their airways, but they can't really because it's the airways are constricted, and there's increased sputum production which doesn't help because their airway lumen is already narrowed, and then you have sputum production which blocks the airway lumens, right? So that's what's just going downhill. Now, in more severe attacks, you can see patients where they're sitting up, and you see you see their ribs going in and out, their nasal flaring in kids, and they have intercostal retractions, that rib where you see them actively pulling air into their lungs and trying to breathe it out. Then when you listen to them with your stethoscope, you hear distant breath sounds and inspiratory wheezing. And they have difficulty. The orthopnea is they can't lay down. They have to sit up. You'll see what they call tripoding, where they're kind of holding themselves up to breathe. They're agitated. They're anxious. It's because they're not getting enough oxygen. When you don't get enough oxygen to your brain, you start getting anxious and agitated. And you don't get enough oxygen in your brain longer than that, you start getting confused. So they start breathing faster, and you'll see their heart pumping faster because now your heart's like, I'm not getting enough oxygen, so I need to increase my cardiac output in order to deliver blood to the tissues. And so it starts to pump faster. Then there's what they call status asthmaticus, and that's the one where this is just a severe form of asthma. It is very, very difficult to turn these patients around, and um, just giving them the usual inhaled bronchodilators, it doesn't work. Sometimes, no, we don't want to do this. It's a very, very last resort, but we may have to intubate these patients, and we don't really we want to avoid that as much as possible. In acute bronchitis, we have acute, so bronchitis, right? It's an inflammation of the bronchi. It's acute inflammation of the trachea and bronchi. And you also see asthmatic bronchitis, where there's swelling of the bronchial mucosa in children, where, of course, it causes obstruction, respiratory distress, and wheezing. So as you can see here with this, the airways become inflamed, they're narrowed, and now you have capillary dilation. And what happens there, remember when we say that, is that they start getting leaky. Then you have swelling from all this exudates that are in there. When your immune system responds, they create all this debris because you have chemical mediators that are out there, like histamine, cytokines, and they create debris. It's like when you cook and you create rubbish, right? It's kind of like that. It's when you're doing something, it creates rubbish. When you're inflammatory, when you're in immune system response, it creates this rubbish and it creates this exudate. And what happens there is your body tries to get rid of it, and then there's mucus in there that tries to get rid of it, and then it's just like an accumulation. It becomes too much where the body can't get rid of it. So there's that infiltration with the inflammatory cells, and mucus is produced. Then your cilia that helps to move that debris along, they're broken, they're damaged. And so what's happening there is, you have all this exudate, use mucus that you can't move out of your lungs. So now you've got obstruction. Viruses and mycoplasma bacteria, they inhibit macrophages. Macrophages are the ones that eat up foreign substances, and then lymphocytes also. So what do you see in acute bronchitis? You might see some, a little bit of cough. It's really hard sometimes to differentiate, and we have to get more information from the patient. And usually, the distinctive hallmark of acute bronchitis is they present with a recent onset of coughing. How do we fix this? So acute bronchitis can be caused by viruses, and usually if you're healthy, you just deal with it and then it goes away. Acute bronchitis caused by bacterial organisms, though, are a little bit more they're a little different, but we can cure them. We can take care of it by taking antibiotics. But really, with acute bronchitis, we just manage their symptoms. But then what happens when that acute bronchitis lasts a long time, like 6 months or more, and it becomes chronic? It becomes chronic bronchitis. So now you have chronic inflammation and swelling of the bronchial mucosa, resulting in scarring. You have fibrosis of the mucous membranes, and you have hyperplasia, meaning that a proliferation there, you create more bronchial mucus glands and goblet cells, which means that you're producing more mucus. And there's hypertrophy of the bronchial glands and goblet cells. So they not only multiply, they become bigger too. So now what? So what happens? You have more mucus production. And then the bronchial wall also gets thicker. So in chronic bronchitis, as you can see in the picture there, in normal bronchus, it's nice and open. You have some mucus glands, a normal amount of mucus to keep the airway nice and moist. Then you have the nice smooth muscle. But in chronic bronchitis, look at how inflamed that area is there. And then now you have more mucus glands in those goblet cells, and they produce excess mucus. So with the inflammation, it makes the lumen smaller, and now you have more. They have an excess amount of mucus that blocks that airway. So what you have there is a very narrowed airway that could be blocked by mucus. So chronic bronchitis can end up being can end up in bronchiectasis. And ectasis is that dilation or distension of a hollow organ. And so what happens here in bronchiectasis is you have dilation of airway sacs because there's destruction of the bronchial walls. Remember, we talked about this, that when your air sacs are dilated, that it can fill up with all kinds of stuff, and that could be something infectious, right? So what are the causes of bronchial wall destruction? It can be from something like pneumonia. It could be this patient just keeps having an acute bronchitis for whatever reason. It could be from this mold, or it could be from mucus plugs or foreign bodies. And it could also be, of course, a problem with the patient or person's immune system. So these dilated sacs, they can contain pools of infected secretion, and it's very hard to clear it. So what happens here, because there's infection in there and it just sits there and you can't get rid of it, then the infection gets worse and you can spread it to other places too. So if it gets into the lymphatics, you can spread it to other parts of the body, like the brain. If these if these lesions are localized, that would be nice because you can just go in and remove that part of the lung. But you know, that's not always the case. So, what do we see in chronic bronchitis? You can see patients are usually overweight. They're in their 30s or 40s. They get very short of breath and just even very little exertion. So they walk from one end of the room to the other end of the room and they're already short of breath. They have excessive amounts of sputum. They're always coughing and they're coughing up stuff. They have this cough that just will not go away. And then you'll see an evidence of excess body fluids, and they'll usually have some kind of history of smoking, which leads us to emphysema. So emphysema is an obstruction. It's an obstructive disease that is related to the loss of lung tissue. How does this happen? Well, so there's destructive changes in the alveolar walls, and there's abnormal enlargement of those air sacs that we talked about. Is usually because the patient has had chronic bronchitis for a while. It could be that it follows bacterial lung infections, but it's usually associated with smoking. Pathologic changes that lead to alveolar destruction is usually associated with these enzymes, such as neutrophils and macrophages. So, smoking is commonly associated with emphysema, right? So, smoking causes alveolar damage in two ways. It leads to inflammation in the lung tissue, in the parenchyma, and it initiates this. Uh, all these events that like we said here, that it releases these enzymes that directly damage the alveolar tissue, and then it activates alpha-1 antitrypsin. Alpha-1 antitrypsin is a protein that's produced in the liver. It usually protects the body's tissues from being damaged by infection fighting agents that's released by its immune system. So when you have alpha-1 antitrypsin deficiency, when you have alpha-1 antitrypsin deficiency, the body's normal production of alpha-1 antitrypsin is reduced. So what happens is that it results in the destruction of sensitive lung tissue. And with the loss of alveolar walls, there is a huge reduction in the pulmonary capillary bed, and of course, there is a problem with the exchange of oxygen and carbon dioxide between the alveolar air and capillary blood. There's also a loss of elasticity in the lungs, which leads to a decrease in the size of the smaller bronchioles. A lot of times when there's loss of lung tissue, there's a loss of what they call radial traction. And radial traction is what holds your airway open. So when that is damaged, and what happens here is that you have increased airway resistance, and then of course it decreases your airflow. So, what do you see with emphysema? You have this progressive exertional dyspnea. They just get, as they are moving around, they just get shorter, they get shorter breath more and more and more. And they're usually pretty thin because, they're not getting oxygenated very well. So, they're not um, metabolizing very well. So, they're very thin. They look kind of I guess they're malnourished looking. They're around 55 years old. They are, like I said, increasing shortness of breath, the progressive exertional dyspnea, and they have difficulty breathing. Then you have the digital clubbing, which is that picture at the top there. You see those bulbous fingernails. They look kind of weird. And then you end up with a barrel chest. This is a picture to your right. Because of all the air that is trapped in there, it can't get out because of this distal air sacs. They collect air in there. So you have these patients that they have air trapped in their lungs, and they can't breathe it out because of all the obstruction. You end up with this kind of barrel chest looking thing. So that's why you see normal chest and not so normal chest. How about bronchiolitis? That is, again, the inflammation of the bronchioles. It's a widespread inflammation of the bronchioles. It's usually from RSV or flu. And RSV occurs usually yearly in winter to spring in children who are younger than 2 years. We used to get these. I was working on North Hawaii ER, and I know that even um, other other places, like in Maui and Oahu, we were seeing them on the Big Island. There was so much RSV, and I remember transporting these patients when I was in California. We used to fly these kids, and they just produce so much mucus, and some of them are so sick. Anyway, the average incubation period is 5 days, with inoculation occurring through it's usually comes from the eyes or the nose. In adults, bronchiolitis is commonly associated with smoking, toxic fumes, and immunosuppression. So let's see here. Oops, what happened? So once this causal agent is initiated, something happens, right? Let's say they get something like a mycoplasma or something that initiates this inflammatory process. Then you have proliferation and necrosis of the epithelium of the bronchi, which is not a good thing. So, you don't want your epithelium in your bronchi to proliferate and then die. What happens here is you produce obstruction and then increased mucus production. We already know how much problems those causes. So there are three possible mechanisms of airway obstruction may follow the inflammatory process. And this could be so how does bronchiolitis occur? It can be from the development of some kind of inflammatory exudate. We said during inflammation, there's sort of debris that accumulates. And this may displace surfactant. And remember that surfactant is that substance that keeps your alveoli open. So if the inflammatory exodus kind of pushes surfactant out of the way, then your alveoli will collapse, right? When they collapse, then you don't have gas exchange. It can also be from the release of chemical mediators, which may produce bronchiolar constriction. or it can be from some kind of inflammation that causes fibrosis and then more narrowing of the airway. And here we talked about this more production of goblet cells and then increased bronchial muscle mass. And all of these result in airway narrowing. What do we see in bronchiolitis? There will be wheezing because of the bronchospasming. You might hear crackles in the lungs, and you might hear decreased breath sounds. So you're trying to listen in, you don't hear that in and out air that you normally hear when you're listening in with your stethoscope. You'll see patients retracting because they're of that inflammation, and then narrowing. It's a narrowing at the airway, so they have a hard time trying to breathe in and out. Increased sputum production. They have shortness of breath and they start breathing faster because they're trying to suck in more oxygen. They may have a little low grade fever because the body's going to respond to all this inflammatory process that's happening. So, cystic fibrosis is an autosomal recessive disorder. It is the most common genetic lung disease in the US, but it's usually um, more in Caucasians, I guess. It's very rare in African Americans and even rarer in Native Americans. It is almost never seen in the Asian population, and there's approximately, I think they said, uh, 35% of the 30 cases of cystic fibrosis are usually um, in individuals who are older than 18 years of age. But they used to die fairly young, but now, I mean, the median survival age is currently 31 years old, which is great. Um, Cystic fibrosis can be classified either as an airflow obstructive disorder or a suppurative or a pus forming. So how does this? So we talked about that it's an autosomal recessive disorder. It's a mutation of the CFTR gene. There's actually a lot more to that, but there's a mutation in this gene, and cystic fibrosis primarily affects the pancreas, the intestinal tract, the sweat glands, and it can cause, and of course, lungs. It causes infertility in males. The mucus producing glands in the GI tract also enlarge and they generate excessive secretions. So, what you see there in the airway with a patient with cystic fibrosis, up there in the first one, where it says normal airway, you see that there's that watery mucus. So that mucus is nice and thin and enough to moisten the air, the lungs. But then in that airway with cystic fibrosis, that mucus is very sticky. It's very hard for them. They can't cough it out. It's just sticks to the lungs, and of course that can trap many things like germs and definitely cause an infection. In acute tracheobronchial obstruction, so it could be from like an aspiration of a foreign body. It could be because when we put in a breathing tube in a patient and it's not placed in the right position or not in the right place even. It could be a spasming of the larynx. It can be from epiglottitis. It can also be from trauma, some kind of swelling from smoke inhalation. And in smoke inhalation, these airways can swell so fast. So patients who are in a fire where there are signs that they breathed in smoke and sometimes ash. So that means that they breathed in all this hot stuff that goes into their airways. Even though they're looking like they're fine, minutes later, their face, their airways could swell so fast that then you'll have acute tracheobronchial obstruction. Post-surgical blood clots can also cause this, and of course, any compression of the bronchus or trachea by tumors. We're talking about that in pulmonary malignancies, that because it's a mass, they block air coming in or blood coming in, and they can also cause acute tracheobronchial obstruction. Enlarged lymph nodes can also cause this. The obstruction can be partially, so your airway can be partially obstructed, or it could be completely obstructed. So what you're going to see with acute tracheobronchial obstruction is that, well, it depends if it's whether it's partial or complete. So you may not hear any movement of air at all when you listen. A lot of times we've gotten kids who've like inhaled marbles and all kinds of beads. So when you listen into, because it could be lodged in their trachea, that would be great, because then hopefully you can get it in, you can get it out. But if it's gone into the lungs, then you have definitely more problems there. But it kind of depends on where it's lodged. So you may not hear any movement of air at all when you listen into the trachea. They may not be able to talk, so you don't want to stimulate them anymore. They're going to start breathing, they're going to start becoming tachycardic, and you might see them start to turn blue depending on where that foreign body went, or where that obstruction is. So if it's trauma, for instance, and it caused an obstruction in the tracheobronchial tree, then you might get cyanosis. And of course, the if the patient is not getting any oxygen into their lungs, then they can progressively go into unconsciousness, and we definitely don't want that. Epiglottitis is a rapidly progressive cellulitis of the epiglottis and the adjacent soft tissue. It is it's usually, acute epiglottitis is you'll have this pain with swelling that seems to be, when you that seems to be disproportionate to pharyngeal findings. So usually they're salivating, they're not able to swallow their saliva. That epiglottis is so swollen that they're having difficulty with swallowing their saliva. The causative organism is primarily um, influenza type B, and it's often seen in children 2 to 4 years old. I mean, this could be really life threatening because it can cause rapid and potentially fatal inflammation with swelling and airway obstruction. We take this very, very seriously when we suspect these in the emergency room. When patients come in, we talked about the drooling because they can't swallow their saliva. They'll have some respiratory difficulty. They can't swallow, and they're not going to want to swallow. They're not going to want to put anything in their mouth when they have this. They have a rapid onset of fever. They can't talk, or they have that hoarse voice. You might hear inspiratory stridor, so that wheezing when they're breathing. You might see inspiratory retractions. And how about that sniffing dog position where when their heads are kind of are back and their nose are up in the air. And then you'll see that oropharynx, which is edematous and cherry red. But with these patients, like I said, we try not to stimulate them too much. So when we suspect that they have epiglottitis, um, we don't even really look in there. We don't look in the mouth and see if their oropharynx is edematous and cherry red. Croup syndrome is a this describes a number of viral and inflammatory diseases of the pharynx. So what you get here is some kind of infectious agent that causes inflammation along that entire airway, and then you get edema and edema in the subglottic area. The patient will, and usually children present with croup, and that child presents with a history of upper respiratory tract infection or cold, and then they have a barking cough. So what we see is, again, the patient will usually have some kind of URI or cold, and you hear, and so one of the things that's asked a lot in tests when it comes to croup is that it's that barking cough with stridor. And they're probably going to get a fever, but it's low grade. They may not even have a fever. But in severe cases, the child may be they'll have stridor, they'll have retractions, and then they're blue, which is never a good thing when somebody's blue. All right.